This podcast is brought to you by the Association for Child and Adolescent Mental Health, ACAM for short. You can find more podcasts and other resources on our website, www.acamh.org, and follow us on social media by searching ACAMH.
Welcome to a different type of In Conversation podcast from the Association for Child and Adolescent Mental Health, ACAM, where we will look at the paper Combined Polygenic Risk Scores of Different Psychiatric Traits Predict General and Specific Psychopathology in Childhood, published in the Journal of Child Psychology and Psychiatry, the JCPP. I'm Jo Carlo, a freelance journalist with a specialism in psychology, and I have with me Dr. Alex Neumann of the VIB Centre for Molecular Neurology at the University of Antwerp, and Henning Tiemeier, Professor of Social and Behavioural Science at the Harvard T.H. Chan School of Public Health in Boston, and Professor of Psychiatric Epidemiology at Erasmus University Medical Centre, Rotterdam. Both are co-authors of the paper that we'll look at in today's podcast. If you're a fan of our In Conversation series, please subscribe on your preferred streaming platform. Let us know how we did with a rating or review, and do share with friends and colleagues. Henning and Alex, welcome. Thank you so much for joining me. Can you each start with an introduction about who you are and what you do?
Thank you for inviting us. I'm an epidemiologist. I study the genetics of psychiatric and neurological disorders. I currently focus on Alzheimer's disease, but my background is actually more in child psychiatry. I did my PhD on the biology of the general psychopathology factor in childhood, together with Henning as my PhD supervisor.
Yes, so thank you for having me here in Boston. I'm a professor of maternal and child health, or I'm the chair of maternal and child health. And for many years, I've been doing etiological research into child developmental and child psychiatric disorders. And I've been leading in the Generation R study for many years, the behavioural and neurodevelopmental research line. So it's really to understand why children develop disorders, and that could be biological factors, but also very often interactions with environmental factors.
And can you also each say a little about how you became interested in the field of child and adolescent mental health?
So for me, it was when I was doing my bachelor in Osnabrück, a German town, and I did my bachelor in cognitive science and was more interested in brain function in general, not necessarily clinical aspects of it. But then I kind of realized during my bachelor how common mental health problems are, something which I wasn't really aware beforehand. And this in combination with the fact that we don't know that much about it, that led me then to become more interested in mental health, and especially in the biological aspects of psychiatry. And so I then further specialized during my master in Maastricht in psychopathology, then was looking for a PhD which would combine genetic research and psychiatric research, and this is how I then found Henning at Erasmus Medical Centre in Rotterdam, Netherlands.
Great, thank you. And Henning, what was your journey into child and adolescent mental health?
There's two things to mention. Once, I had to go to research because I moved for private reasons to the Netherlands from Germany, and I didn't speak any Dutch, so working as a psychiatrist was no option. So I went into research just for practical reasons to learn the language, and I stayed and loved it. Mm-hmm. And I went into research of psychiatric problems in the elderly, and I liked it. And then after a while, they asked me to help run a study in children, and that was more because I was perhaps trained well as an epidemiologist, and I was very good at managing data collection. And my mentor then said, "Oh, I'll train you in child development." And he really did, and I stayed for 20 years now.
Let's turn to your paper, Combined Polygenic Risk Scores of Different Psychiatric Traits Predict General and Specific Psychopathology in Childhood, published in the JCPP. Can you set the scene? What did you look at and why?
So if you think about a typical genetic study in the psychiatric field, how it's often done is you have participants with a particular diagnosis and then a control group without a psychiatric diagnosis. Let's say, for example, you have participants which are diagnosed with ADHD, then you have a control group who do not have any psychiatric diagnosis. And then you can test millions of variants, of genetic variants, and compare for each of those variants, do they occur more frequently in children with ADHD, or do they occur less frequently compared to the control group, or perhaps are they approximately the same? So if you perform such a genome-wide association study, you then get estimates for each of those genetic variants. And the effects of single variants are typically very small. However, you can aggregate the effects of many different genes. Depending on how you do it, it could be an aggregate of hundreds of thousands of variants. So if we stick with the example of ADHD, so your expectation would be then, if you perform such a study comparing children with ADHD to those without, and then you create a genetic risk score based on the information of your genetic study, then trying to aim to predict whether somebody develops ADHD given their genetic risk. Your expectation would be then you can take this information from your study and then predict reliably ADHD in children. However, what researchers have noticed is that while those genetic risk scores based on these genome-wide association studies do, for example, predict ADHD symptoms, they also predict lots of other different symptoms, which you would normally think immediately about in regards to ADHD. So, for example, a group from Karolinska Institute, they saw that a genetic risk score for ADHD predicts ADHD symptoms, but also symptoms such as depression or anxiety and many different other psychiatric problems. So it seems to be that a genetic risk score for ADHD is actually a quite general risk score. And so then the question came up, is this something special about the genetics of ADHD or the genetic risk score for ADHD that it's so seemingly has such general predictive ability? Or is this something which can be applied to also other risk scores? Maybe that's just how psychiatric genetics works. Maybe if you create a genetic risk score for one particular disorder, maybe what you get is then a prediction for many different disorders.
I want to ask you a bit about the methodology that you used in the research.
We try to test a broad collection of different polygenic risk scores, or PRS, essentially systematically get an overview how general or specific different PRS scores are. In total, computed 16 different PRS scores for different psychiatric traits or disorders such as schizophrenia, depression, as mentioned, ADHD, but also related traits such as cognitive ability or neuroticism. And then we tested for each of those 16 polygenic risk scores whether they predict child psychiatric symptoms in general, or whether they have predictions for specific psychiatric problems in childhood. And to get into more detail, specifically, we looked here at the associations with general psychopathology factor and specific psychopathology factors. And maybe Henning can a bit more about those factors.
So first, the terms general psychopathology factor and specific psychopathology factor are not so easy. And they were coined a few years back by Ben Leahy, who did the following. He said, with a sort of factor analytical technique, he pulled out from different disorders what is in common. So he had the idea that all people who are vulnerable to one of the different psychiatric disorders share something in common, have the same traits and characteristics, if you wish, so that there is a liability to have any disorder. And when you do that, you also, with this technique, obtain what's not part of that general disorder, but what is more specific for emotional problems or more specific for behavioral problems as aggression, so that you get these general and specific psychopathology factors, if you wish.
What can you share of the findings?
So we associated these 16 PRS scores with general and specific psychopathology, and we found that out of the 16 we tested, 7 PRS scores associate consistently across 3 different cohorts with general psychopathology. So we have 7 polygenic risk scores which associate with psychiatric vulnerability to different psychiatric disorders in general. And there was no particular pattern to it. There were very different PRS scores. So there's a PRS score for ADHD, genetic risk for depression, genetic risk for schizophrenia, but also genetic risk for cognitive ability and neuroticism. So very different PRS scores. They all were associated with general psychopathology in children. The predictive ability of this score was at most 1%. So each score individually explained at most 1% variance in general psychopathology in childhood. This is was our first main finding, is that we have the observation I initially elaborated on regarding ADHD, that ADHD seems to have a very broad association, very broad predictive ability towards different disorders. That doesn't seem to be the case just for genetic risk for ADHD, but seems to be a more common phenomenon that genetic risk towards other disorders also shows this broad predictive ability. And so then our next question was, okay, if all these 7 PRSs associate with general psychopathology, can we maybe perhaps combine them and then have even better prediction of general psychopathology in childhood? So in other words, if you're genetically vulnerable to both ADHD and, for example, to depression, do you then have a higher propensity for psychiatric problems in general? And saying this out loud, it seems kind of obvious, the answer. Yeah, probably, right? But actually, it's not quite that obvious, because let me give you an example. So let's say we have a genetic risk score, which is based on 2 genes. Let's say for ADHD, and we have 2 genes. One gene is called general gene, and a second gene called ADHD gene. And then we might have the genetic risk score for depression, which also has a general gene and includes then also a depression gene. So in this case, we have 2 times the same general gene. And so it wouldn't make sense to combine these 2 genetic risk scores, because you're essentially just counting twice the same genes which have general effects. However, this is not what we saw in our results. We could combine the 7 genetic risk scores and saw that they have, almost all of them had independent effects, which then has the consequence that we could actually improve our predictive ability. We could double it from 1% to 2% if you look jointly at different polygenic risk scores at the same time.
It's complicated, as you know, so let's try it a bit differently. So the first thing we noted is that if you try to predict child psychiatric disorders, you can do it, but you don't do it very well. What you explain is very little. That is the first observation. The second observation is that if you predict, in this case, general psychopathology, you can predict it with very different polygenic risk scores from very different disorders. And the next observation is that you can predict it independently. So each of these disorders, of these polygenic risk scores, adds more information. So you can predict it a bit better and a bit better and a bit better by ever adding the information from different risk scores. And what does that tell you? It tells you that indeed, genetically, this general psychopathology is indeed found from very different disorders, but it's found across all the different disorders. So they indeed all have this aspect of a general vulnerability, or that you could say all our different disorders are driven by, in part, driven by similar things.
It is complicated. I want to go more into the implications. So, Alex and Henning, in your paper, you describe how polygenic risk scores associated with school-age psychopathology tended to either be associated with general psychopathology only, or general and specific, but not, except in the case of anxiety, specific psychopathology only. Can you explain to the layperson the importance of that finding and what it means for assessment and diagnosis?
So indeed, we had 2 polygenic risk scores which predicted specific externalizing psychopathology and 5 which predicted specific internalizing psychopathology. However, as you noted, there was almost complete overlap with those genetic risk scores which predict general psychopathology. And yeah, it's a bit difficult now to translate it into what does this mean practically, since the constructs of general and specific psychopathology are a bit abstract. But the way I think about it is, so right now, as mentioned, the predictive ability of our current PRS scores are not very reliable, and they're not used clinically yet. But for the sake of this question, let's pretend we are a bit more further ahead in the future, maybe, where we get more reliable PRS scores. I think the implication then is that, let's say you have 3 children, and one child scores high for genetic risk for ADHD, a second child scores high for genetic risk for depression, and a third child does not have high scores for any psychiatric disorder. So given that you know the genetic risk for each of these 3 children, you would then expect intuitively that the child with the high ADHD score would most likely develop ADHD symptoms. The child with high depression scores would develop depression, and the child with low scores is not at risk and would probably not develop a psychiatric disorder. This is compatible with our findings. However, what you have to realize is, because of the strong associations with general psychopathology, the difference between the child with a high score for ADHD and high genetic score for depression is actually very similar. In other words, the child with a high genetic risk score for ADHD is also very likely to develop depression. Vice versa, the child with a high genetic score for depression is also very likely to develop ADHD symptoms. So yes, it's not all just general psychopathology. We do have some specific predictions, but what we need to, I think, realize, or what the implications of these findings are, is that there's lots of overlap, and that genetic risk scores for a specific disorder also very likely predict risk for many different other symptoms as well.
Can I add something? So for me, the lesson we learned from these studies is that I think we should, in psychiatry, think more of this general vulnerability for psychiatric disorders. This is not at all represented in our DSM. That means the typical classification system we use to diagnose mental disorder. Whereas we in cognition think of a general intelligence, we lack something similar like that in psychiatry. And the other side of the coin, I think it means for our diagnostic system and our diagnostic thinking is that we probably, if we come to genetics, think too small. That means we split up the diagnostic groups in ever smaller categories, ever specific categories, subtypes of depression, many subtypes of anxiety. And at least at the moment, it seems that genetically, if you just look at the genetics, that's not justified. And I must say, if you look at environmental factors, it's equally not justified.
But I'm wondering, given what you said about the general vulnerability and the limited way that it's looked at the moment, what are the implications of your findings for professionals working with young people and their families?
Well, this is indeed related. I think one of the things we must realize that in child psychiatry, the idea that we can use genetics for prediction is not close by, but on the far horizon, if it will ever come, but it's not there. It's different in adult psychiatry, but it's far away to use genetics for prediction of disorders. Secondly, I think personally that we must point out that this study was conducted in different cohorts from the UK, from the Netherlands, and Canada, but they all share, like all these psychiatric disorders, largely the characteristics that it is maternal report on which the classifications and the ratings are based upon, which makes it very hard to find a large genetic signal. And thirdly, I think if you really ask, what does it mean for professionals? I think they must realize that a child they see with one disorder, let's say ADHD or autism, might have a different disorder later. A child with anxiety or psychotic experiences may have borderline depression, anxiety later down the road. These disorders, they know, are not stable clinically, but they know that the genes do not define stable course either. That's, I think, what they must realize.
That's really helpful. And what about the message to researchers in this field?
I think there's two aspects I would like to mention. So one is that if you're trying to create genetic prediction scores for a psychiatric disorder, I think you should consider using multiple genome-wide association studies as a basis for your genetic risk scores. As we saw here, the combination of different GWASs seems to improve prediction of psychiatric outcomes. And I think also you could also even consider genetic studies which are not on, strictly speaking, psychiatric outcomes. For example, one thing which should surprise me here is that genetic risk for cognitive ability was one of the best performing PRSs in terms of prediction of general psychopathology. And cognitive ability by itself is not a psychiatric outcome. So I think this shows that it's worthwhile to combine different genome-wide association studies if you want to do prediction of a specific disorder. And I think the second message, I think we have to be careful when interpreting results from polygenic risk scores or polygenic risk score studies. Some of your listeners might be familiar with Mendelian randomization studies. And I don't want to go too much into detail here, but essentially you can use genetic risk scores to quantify genetic risk towards a particular trait, and then you can link it to another outcome. Let's say you want to link genetic risk for depression to obesity, for example. Mm-hmm. And in this case, you have to then be careful if you then make conclusions, for example, that genetic vulnerability to depression is linked to obesity, that it might be actually more genetic vulnerability to psychiatric problems is linked to obesity. So you have to be careful how specific your conclusions can be.
I would like to make for researchers on a sort of more abstract level 2 big points, I think, to take away. One is we need to understand better and do more research into pleiotropy. That is the concept that one genetic variant has different effects in the body. And that can be for many, many reasons. That could be because one disorder down the road causes another. So you might be more vulnerable to depression because you have anxiety. But it could also be that one gene causes anxiety and depression by very different pathways. So this phenomenon of pleiotropy, which seems to be more common than we thought, more complex, with bigger studies, more prominent, is poorly understood, and I would argue poorly researched in its quality, certainly in psychiatry. And the other closely related point is comorbidity. That is the co-occurrence of different disorders. In our studies, which are increasingly longitudinal, we still don't take care of why 2 disorders co-occur, why they co-occur in time, and how to deal with it. Sometimes we ignore them. For example, in imaging research, we don't know what to do with that. The signal that we see for one disorder could actually be because there is another disorder commonly co-occurring. So the signal we see for ADHD might be because there's also anxiety or autistic traits.
Just returning to the paper itself, is there anything else in the paper that you'd like to highlight?
You mentioned most interesting things. One thing which I personally find interesting is how often neuroticism comes up in research of general psychopathology. So we talked already about cognitive ability as a non-psychiatric trait, but I think neuroticism is also another important correlate of general psychopathology. So we have non-genetic studies which often find a high correlation between measures of neuroticism or stress reactivity and general psychopathology. And also here we see that genetic risk scores for neuroticism also are predictive of general psychopathology. So that's one thing which also I think is quite interesting, and maybe also has some broader implications.
I think that's a wonderful point, Alex. Let me just emphasize it. I think it's been realized for many years that psychiatric disorders are genetically related to other non-psychiatric disorders like smoking, when you have the first child, your cognitive abilities, your body mass index. And what we see here again, that even in children, psychiatric problems are related to the genetic risk for all these others. So that it's there even in the common child psychiatric disorders. I think that point of Alex is really important.
What about conclusions? I mean, what did you conclude in the paper?
Our conclusions were that we see now, not for the first time, but here very strongly, biological plus genetic evidence for this construct of general psychopathology, this general psychopathology factor that I described earlier, that we see there is a genetic correlate, if you wish, for this vulnerability that each of us may have to some degree to psychopathology. So that means we can think of us as having like an intelligence trait. We can also think of us like a trait of psychiatric vulnerability, which is genetically determined and likely also environmentally determined. I think that this paper is one of very many, but it's sort of the increasing papers that will make us think about, do we have to reshape our diagnostic categories and diagnostic categorization methods to be more broad and encompass broader categories of disorders? That's another takeaway.
I think maybe one just thing to add, which I find also important. So we've been talking a lot of genetic risk today, but of course, genetic risk is always a probability. Like sometimes people think that genetic factors are these fixed deterministic things. which cannot be changed and you cannot do anything about it. But when we talk about genetic risk, especially here, we're talking about descriptive probabilities, and it might be difficult in practice, but at least conceptually, there's always the potential that there's things you can prevent or treat from problems from occurring.
Are you planning some follow-up research that you can reveal to us?
Yes, so currently we are looking into incorporating the environment in our risk predictions, because even with highly heritable disorders such as ADHD or schizophrenia, you still have a substantial environmental component, which we at some point have to integrate somehow into our risk prediction systems. So the same team which was working on this paper, and we are now also looking into specifically the pregnancy environment. So things like stress, maternal stress during pregnancy, or maternal depression during pregnancy, how this might interact and interplay with genetic risk for disorders, whether it has some additive predictive value, but also whether there might be also some interaction effects going on, so that you might be especially at risk if you have both a genetic risk and perhaps an environmental risk during pregnancy, which then combined could especially result in high risk to develop a disorder. Or maybe the other way around, maybe especially good environment might protect you from genetic risk factors. So those are the things we are currently looking at.
I can add 2 current ongoing projects of mine. One is looking at what I mentioned before, this pleiotropy, which I defined as genetic risk factors or genetic loci having effects on different outcomes, or in this case, different psychiatric disorders, together with a team from Rotterdam. And we're trying to develop a new statistical methods to look at this phenomenon, because we think we're getting it a bit wrong. So we might try to change the way we look at it statistically and redefine it a bit, because I think what we do is we're just pooling everything together, and then the biggest signal takes over, which is not really what we should do. So that is quite statistical. And the other is perhaps more interesting for the listener, is that there is good reason to assume that our understanding of environmental risk factors and genetic risk factors is ever increasing. But what I think we can now do better, and I think a colleague of ours in King's College has shown that with a wonderful new method, J.B. Pingot, he's shown that we can use the heritability together with these polygenic risk scores to look at how much genetic factors underlie things we always thought were environmental, that we're redefining what is environmental, what is parenting, what is screen time, is that really partly driven by your own genetics? And the other way around too, because there's colleagues in Sweden at the Karolinska who showed that all we do is this polygenic risk scores, in part, in some of them, may be essentially, there may be a bit of error and there may be a bit of non-genetic effects in them. So then we have to rethink what we think is genetic and think it's environmental. And that's 2 fascinating roads of research.
And finally, Alex and Henning, what are your takeaway messages for those listening to our conversation today?
Yeah, I think we have to really be mindful of co-occurrence of psychiatric disorders, whether they occur because of common genetic factors, whether it's common environmental factors. Either way, I think it's sometimes easy to just focus on one particular problem or one very salient symptom, but I think it's both from a research and probably also more prevention or treatment perspective. It's really have to look at the whole complexity of psychopathology. So I hope that this will also then help us to better prevent and treat psychiatric disorders in the future.
Thank you. And Henning?
I'll give you my takeaway. I have no doubt that there is a general psychopathology factor. I have no doubt it's partly genetically determined, but I have no doubt that at the moment we cannot predict it well at all. That is my takeaway.
Thank you both so much. For more details on Dr. Alex Neumann and Professor Henning Tiemeier, please visit the ACAM website, www.acam.org, and Twitter @ACAM. ACAM is spelled ACAMH. And don't forget to follow us on iTunes or your preferred streaming platform. Let us know if you enjoyed the podcast with a rating or review, and do share with friends and colleagues.
This podcast was brought to you by the Association for Child and Adolescent Mental Health, ACAM for short.